Good afternoon, post-lunch session. And this session is for the interstitial lung disease, the most emerging respiratory problem, not only in India but across the world, and rather more challenging disease. Out of various types of ILD, the interstitial, among the interstitial lung disease, the idiopathic pulmonary fibrosis is somewhat very serious. Once it is diagnosed, then it is almost death sentence. So we have a big challenge to diagnose, to manage, and to lengthen the longevity, life survival, and that too without morbidity, but huge morbidity as the disease progresses and the morbidity increases, and then end of life care. The definitive diagnosis is the lung biopsy, but CT thorax and multi-modality diagnosis and clinical symptoms on that ground, we diagnose the case. But the definitive treatment is again a challenge, and the lung transplant is the final treatment. So we have for this session Dr. M.K. Sen sir, and he is Professor of Respiratory Medicine, ESIC Medical College and Hospital, Faridabad, Haryana. He was formerly consultant and professor, VMC, Safdarjung Hospital, New Delhi, and he has been a recipient of many awards and WHO in country fellowship in medical biotechnology in AIIMS, New Delhi, fellow of ISDA, IMSA, NCCP, ACCP, member of ATS, ICS, Professor K.C. Mohanty, NCCP, Lupin Award, and oration, and many orations.
Thank you, sir.
No signal.
Thank you very much, sir, for those kind words.
So,
at the outset, I'd like to thank Dr. Ashutosh Gupta, and it's a commendable job that is being done today, and the entire organizing team of the Allahabad Medical Association for this conference. As Chairman sir had just pointed out, in the next few minutes, I propose to discuss on a not so uncommon disorder, but which is unfortunately very often missed and misdiagnosed, or diagnosed very late. So the topic of the day is obvious. It's an early diagnosis and management of idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis is, as we all know, a member of the larger umbrella term, which is interstitial lung diseases. And it's a heterogeneous group of lung parenchymal diseases, which involves the interstitium, the area between the alveolar epithelium and the capillary endothelium, which is a huge space, and the gas exchanging surface. It is characterized by symptoms. The common symptoms are exertional dyspnea and cough. It's a dry hacking cough. And on physical examination, you'd find digital clubbing and, most importantly, inspiratory crackles. And pathologically, it is characterized again by all shades and grades of inflammation, which progresses relentlessly to end-stage fibrosis. And as was pointed out just now, it is a disease which is perhaps a death sentence for a patient. It used to be and still is, despite all the treatment that we have, which is emerging. Now, the interstitial lung diseases, of course, one should make a very meticulous search for primary causes, to which ILDs can be secondary. The commonly encountered causes are the autoimmune diseases like rheumatoid arthritis or systemic sclerosis, or it may be exposure to some hypersensitive to some of the environmental antigens, whether it's birds or farm products, or moldy hay as in farmer's lung, or occupational exposures to asbestos or to coal workers' dust, and maybe drugs like amiodarone, long-term use of amiodarone or nitrofurantoin. Or it may be the granulomatous disease. The typical granulomatous diseases being sarcoidosis and hypersensitivity pneumonitis and so on. But even at the end of this meticulous search, if one fails to identify a cause, then the interstitial lung diseases are labeled as idiopathic interstitial pneumonias. Now, as we know, the idiopathic interstitial pneumonias again form a very sizable proportion of the interstitial lung diseases, of which the interstitial idiopathic pulmonary fibrosis happens to be the largest. So it is, in fact, not only the largest, but it's the most aggressive form of interstitial lung disease. It is chronic, it is progressive, and it leads to fibrosis. And once, as we all know, fibrous tissue is laid down, there is no reversal. It's only the end of the story. So it leads. There is a progressive respiratory failure, and the patient is almost a cripple. It is associated with a very high mortality rate, and the incidence. This morning we heard about pulmonary embolism, which is about 69 per 1 lakh. Here it is about 40 per 1 lakh. So 4 per 10,000. That's the global estimate. The median survival if a patient is not treated, untreated, is about 3 to 5 years. And even with treatment, it can at best be extended to 5 to 7 years. So the early diagnosis. A timely introduction of antifibrotic agents and drugs which have been shown to slow the progress but never revert the progress. It slows the decline in the lung function by about 50%. And to prolong the survival of the patient, it benefits of this early intervention can rely only on early diagnosis. So what is important? The most important is a meticulous history. We must go on to take a very deep and detailed history of all the exposures that I pointed out, what has been the temporal profile of the disease, and a physical examination. Radiology, as was just pointed out, is of paramount importance. And we must take into confidence our colleagues from radiology, from pathology, and engage in a multidisciplinary discussion before we arrive at a definite diagnosis. And of course, we have the serological biomarkers and the genetic studies, markers, which are also emerging. So what is characteristic? Just, it's a recapitulation of whatever we do every day. So the physical examination would reveal digital clubbing and crackles. So we all know crackle is a discontinuous sound, which is, a non-musical sound. And these crackles are softer, shorter in duration, and higher pitched as compared to the coarse crackles. And these fine crackles, they are basically designated as Velcro crackles. Velcro crackles, meaning thereby that when you disengage two surfaces which are stuck by Velcro, as in a sphygmomanometer cuff, the sound that it is produced is typically heard and mainly over the lower thoracic areas, which is the inferior axillary, infrascapular, and interscapular areas. And compared to the later appearance of the usual interstitial pneumonia pattern, and come to what that means, the UIP pattern, which is seen on a HRCT, the physical examination of crackling comes much, much earlier. Hence the importance of a very good history and a very good physical examination. So what is the current diagnostic norm? Well, on the basis of HRCT, as was just pointed out, we can classify the images into 4 diagnostic patterns. The first one, which means it is the usual interstitial pneumonia pattern. And we'll come in a short while what actually that means. So either it could be a UIP, definite UIP pattern, or it could be a probable UIP pattern. So if we have these 2 categories of patterns on HRCT, we can actually do away with a biopsy. So a biopsy is no longer required. We can, in the backdrop of a proper history and physical examination, if we have these 2 particular patterns of UIP, that is definite or probable, on a CT, HRCT, we can diagnose IPF for sure. But if we have the 3rd and the 4th varieties on the HRCT, which is the indeterminate UIP pattern or an alternative diagnosed to UIP pattern, then of course we must go in for a lung biopsy. So these are the common, the patterns that we see. Over here you can see the definite UIP pattern. This is a reconstruction of the CT scan, which shows that mainly the peripheral portions of the lung are involved, and it's the subpleural portion which is involved. The central portion is characteristically, left free. So this the basal and peripheral involvement of the lung, which also is, with sparing of the upper regions, upper and the mid zones, and the central peribronchovascular zones, is classical UIP. So to diagnose it as UIP, one must have reticulation, or the network-like shadows that you see. You must have traction bronchiectasis, which is basically not an involvement of the bronchus primarily, but the bronchus is being pulled apart. The lumen has been pulled apart by the fibrous tissue that is growing all around it, which is clearly known as tractional bronchiolectasis and tractional bronchiectasis. We must have honeycombing, which is the beehive-like structure that you see, the cystic circular spaces, which are typically around 3 to 10 millimeters or up to 25 millimeters in diameter. And they are lining the subpleural regions. So we have tractional bronchiectasis, we have honeycombing, we have reticular shadows, and we also have the basilar distribution. So if we have all these 4 characteristics, we term it as typical or definite UIP pattern. The second image, which is labeled as B over here, you can see that everything that goes with typical or definite UIP is present, except for honeycombing. So if we don't have honeycombing, we call it a probable UIP. So these are the 2 scenarios where HRCT comes to our rescue and the patient is spared of the surgical intervention, which is lung biopsy, which can of course be very, very morbid and at times difficult in such cases. The third image that you can see doesn't have any of these characteristics that were mentioned. The apices are also involved. We have no honeycombing, we have no or little traction bronchiectasis. So here it becomes indeterminate. We really can't predict whether there is IPF or is it some other type of interstitial lung disease that this is depicting. So here we must go in for a lung biopsy. This is again definite UIP. So whenever we are asking for a CT, we must do a prone position CT. And we also must do an inspiratory and an expiratory CT. So we must request our radiologist colleagues to go in for this, because you can see that the little that we see of honeycombing in the supine CT, the honeycombing is more marked, as has been depicted here by the red arrows, if the patient is turned prone. So the prone position CT comes of help with scanty features of or early features, early diagnosis of IPF. Here we have a probable UIP pattern. Again, we have no honeycombing, right? We don't have honeycombing, but all other features are present. The peripheral calcification, which are also included in the 2022 guidelines, which is also known as the dendriform pulmonary ossification, which are small areas of ossification of the subpleural lung tissue. This is also characteristic of the UIP pattern and probable UIP pattern. And again, minimal intensity projection. This is another area where the radiologist is actually doing some jugglery with the images by having this minimal intensity or MINIP projection, which can highlight the areas of honeycombing. So indeterminate, again, needs a lung biopsy, I told you, because they don't have all the characteristics. This is an alternative pattern. You can see areas of ground glassing over here, peripheral ground glassing. This is an eosinophilic pneumonia. This is a case of non-specific interstitial pneumonia. None of these features match UIP. So here we need a lung biopsy. Here we have sarcoidosis. This is the peribronchovascular central patterns. This is organizing pneumonia. So none of this matches into the UIP pattern. So, and this is inspiratory and expiratory, because this is a case of hypersensitivity pneumonitis. Typically we have 3 density pattern over here, where we have ground glassing, we have the normal lung tissue, we have the hyperlucent lung tissue. And this pattern is exaggerated. The hyperlucent areas are exaggerated if the patient is having an expiratory film. So this is another place where the radiologist comes of help. That is why again and again the multidisciplinary discussion is of prime importance. We must have these special views. This is definitely not early. This is a late stage or end stage IPF, which is, The next modality that we come to is histopathology. So what is the characteristic of IPF? On histopathology, we again have this term again and again coming, which is UIP, or usual interstitial pneumonia. So UIP with HRCT we just saw. What is UIP with pathology? Well, in pathological terms, in pathology parlance, UIP actually should have a temporal heterogeneity of all the characteristics, which means there will be normal lung tissue, there will be fibroblasts, which are early fibroblastic cells, not started laying down the extracellular matrix or the collagen. Then we have, fibrosis, a genuine fibrosis, which is we have fibrous tissue there and a lot of collagen and extracellular matrix, all in the same section. Like we see in this micro photograph, we have normal lung, we have fibroblast focus, and then laying down of fibrous tissue and end-stage fibrosis, all in the same microscopic view. So the pathologist will tell you, yes, this is UIP. So even if you don't have an HRCT pattern, the pathologist will come to our rescue. So the multidisciplinary discussion. And then the current diagnostic criteria, these patients are sometimes, respiratory, the symptoms are so devastating that they would very poorly sustain or tolerate a surgical procedure, whether it is a surgical lung biopsy or a bronchoscopic lung biopsy. So we can go in for a transbronchial cryobiopsy instead of doing a frank surgical lung biopsy to have a surgical tissue. So these are some of the other features which we mentioned, which should be ruled out meticulously before we arrive at a diagnosis of IPF. Now, why the diagnostic delay? It has been seen that almost 2 years pass very frequently, very commonly we find it's been 2 years after the onset of the first symptom of cough or dyspnea that the patient is labeled as IPF. So before he is labeled as an IPF, he's taken up for the more common diagnostic entities like COPD, asthma, heart failure, and a lot of time gets wasted. The antifibrotic treatment, which could be actually started 2 years back or 3 years back, is started much, much later. So this is what we should avoid if you go in for an early diagnosis. So some people have come up with what is early. How early is actually early? Some authors have said that this IPF actually has the stages of early, middle, and advanced stages. In the early stages, the patient will have scant symptoms or no symptoms at all. Maybe the HRCT will not show you all the features that we just enumerated. It will show you maybe some incidental lung abnormalities, which are interstitial ILAs, interstitial lung abnormalities incidentally found unsuspectedly, or they may have indeterminate forms. So here is the role of surgical lung biopsy. On a surgical lung biopsy, you can have the typical UIP pattern, and you can straight away go in for a diagnosis. So this is early stage. Some people say on a CT, if the fibrosis score is fibrosis, actually the radiologist gives you a score of how much fibrosis has taken place. So if the score is less than 10%, that is early IPF. So early IPF, less than 10% fibrosis score, or scant or little radiology, but surgically one has to prove it. Then interstitial lung abnormalities. Sometimes you don't suspect ILD, but you're just doing a screening or doing a CT for some other purpose, and you find incidentally some features of ILAs. These are incidentally discovered interstitial lung abnormalities. So these lung abnormalities are said to progress, some of them, because ILAs can be classified as subpleural, non-subpleural, and the subpleural can be fibrotic and non-fibrotic. It's the fibrotic variety of the subpleural ILAs which have been seen to progress eventually to IPF. So if they're picked up early, you can treat them early. So ILAs on CT, which are done in patients who are least suspected of IPF or ILDs, if incidentally found, you can go in for a biopsy and prove them to have a UIP pattern. These are some of the ILAs which are seen on CT scans. What is new in HRCT? Well, HRCT, if even for a respiratory physician or for a radiologist or for anyone for that matter, there is an element of fatigue. If somebody has to see 50 CTs on a day, he'll definitely miss out. He'll miss on things. So computer-aided diagnosis or artificial intelligence. You have these deep learning methods, machine learning methods, artificial neural networks. So you train the machine and give them, develop an algorithm into the machine where they'll pick up these things much earlier. Things have been done in lung cancer screening. Things have been done in TB. So why not in IA? So you have algorithms to pick up these shadows based on a computer-aided diagnosis. That is something new which has come. What is new in bronchoscopy? I told you that bronchoscopy can give you very little things. Conventional bronchoscopy giving TBLB will give you small biopsies, maybe just 3 or 4 microns. So you go in for larger biopsies with cryobiopsy, transbronchial lung cryobiopsy, which is less invasive. Or you can go in for surgical biopsies. But newer methods like OCT, which is optical coherence tomography, OCT or endobronchial OCT is one such method where you can actually put in small, these probes through the instrument channel of a conventional fiber optic bronchoscope and go on to the peripheral regions. And this uses near infrared rays, which the scattered light from the near infrared rays will actually simulate or give you the picture of 2 to 3 millimeter deep tissue. They'll give you the identical to the pathology picture. They'll show you if there is any honeycombing, if there is any traction bronchiectasis on images obtained from bronchoscopy. So that is something new which is coming up, not yet come, but it's coming up. That is the endobronchial OCT and the polarization sensitive endobronchial OCT. The other advances that have been made in early diagnosis is genomic classification. We have a set of 190 gene genetic sites which can be the tissue, the biopsy tissue that you've taken on the basis of surgical lung biopsy or whatever, transbronchial lung cryobiopsy. You subject them to genomic classifier. So there are systems of genomic classifiers which can identify those genes or those genetic entities which are prone to go on to progress to IPF. So you can pick them up early. So you have the TOLEP gene, you have the mucin 5B gene, and so on and so forth. Then you have various serum or blood biomarkers like the circulating CK18 or some of these biomarkers. They were too early days, but we are seeing very exciting times we're going through. So we can have methods to identify this disease much, much earlier so as to pick them up early and put them on treatment. Well, you have the scoring systems which can identify, at least prognosticate what is the prognosis of a patient. You have the gap index, which is a conventional gender, age, physiology. Some people have included HRCT also in it. So you have the gap index, Du Bois index, composite index. These are indexing systems like many other diseases which can prognosticate. And of course, the ghastly, very sinister entity of acute exacerbations. Like you have acute exacerbations of asthma, you have acute exacerbation of COPD, you may have acute exacerbation of ILD. So, the IPF actually has an acute exacerbation at times. So you can see there are various profiles of the IPF patients. Not all of them behave similarly. Some of them, as you see the top curve green, it is initially stable and then suddenly dips after an acute exacerbation. And then there is another group which has a slow progression. And then there is another group in the red which has a rapid progression. So it is this rapid progression and the rapid progression particularly after an acute exacerbation which is very fearsome because these acute exacerbations are very resistant to treatment. People have tried pulse doses of steroids, anti-inflammatories, it really doesn't help. And then you have how to treat. Well, you have two very definite, 2014 onwards, we have these antifibrotic drugs. We have pirfenidone and we have nintedanib, and recently we have nerandomilast. These are two or three drugs that we have at our disposal. Not that they are panacea for these patients, but they definitely slow down the fibrotic process. They can't revert whatever fibrous tissue has been laid down. No, that will never happen. But they can retard or slow down the fibrotic process. So this is the antifibrotic medication. It should be put from day one when you diagnose. No question of waiting. No question of beating about the bush. No question of, treating him as a COPD or a heart failure. Just diagnose and start him on antifibrotic. At least whatever little we can do, we should. So early diagnosis will put these patients on antifibrotics. What are the antifibrotics? We have pirfenidone, we have nintedanib, and the new kid on the block is nerandomilast, which is nerandomilast is basically a phosphodiesterase 48 inhibitors. Now we have many in the pipeline. We have inhaled pirfenidone. We have inhaled inhaled treprostinil. Treprostinil is a drug which is used in pulmonary hypertension. So we have very, very exciting things coming. So these are, then there are recombinant human pentraxin and Galapagos and a host of other drugs which are still in the phase 2, phase 3 trials, which will be there. But 3 drugs definitely we have right now, and we should put them. The doses are there on the table. You can see 2,400 milligrams in 3 divided doses, or 100 to 150 milligrams twice a dose. Now, these drugs have very little side effects. Now, this is the algorithm, it's a busy slide, but the definite entities that we should focus on are A, antifibrotic treatment, which I've outlined. B, symptom management. These patients need a lot of pulmonary rehabilitation. They need to address the symptoms of cough. They need the supplemental oxygen. They need palliative care. Then risk mitigation, like a lot of comorbid diseases, smoking cessation, exposure avoidance, vaccination, then things like gastroesophageal reflux, sleep apnea. So all those things need to be addressed simultaneously. Assessment and treatment, periodically we should do these assessments, how far the patient is responding, to what extent, if it needs any change, and of course, then the patient can be a stable disease or there can be an acute decline. Acute decline is usually the acute exacerbation. The other modalities we should look for are lung cancer, rehabilitation, cardiovascular morbidity, and lung transplantation, as sir had just pointed out. But amongst all the indications of transplantation, is perhaps IPF is the worst. Even if you transplant these patients with a transplanted lung, also the survival is very poor. And the last few slides, this is again the various other issues that need to be addressed are breathlessness and cough. Despite treatment, the patient will never tell I'm better. Only these pulmonary functions would show some improvement. The rate of fall will fall down, but he'll never say they'll better. So the symptoms of breathlessness and cough need to be addressed anyways. Then fatigue, supplemental oxygen, anxiety, depression, end of life care. There are so many issues that need to be taken care. So the final slide is, it sums it up. That is, what are the current status? The current status is early diagnosis and treatment of IPF is of great benefit. Diagnostic delay is prevalent. We know that a lot of delay happens. That needs to be curtailed. Identification of IPF possibly with, as ILAs remains challenging. The non-specific symptoms, the insidious onset of symptoms, misdiagnosis as other entities, they are mainly the causes of delayed diagnosis. The newer diagnostic tools include the endobronchial OCT, molecular biomarkers, lung ultrasound, and so on and so forth, and the various other issues that I have pointed out. So I think in the interest of time, I'll end over here. If there are any questions, sir, I'd be happy to respond.
Thank you very much, sir. Very good presentation of the relatively tough subject. And recent updates also included. And now my questions, but before that, I'd like to ask audience if they have any question, please ask sir. Audience, please.
Sir, आप ही अपना question पूछ लीजिए.
Anyway, sir,
think about
my question is that, sir, the interstitial lung abnormality, now very well known, is a pre-fibrotic condition, and that is diagnosed in the CT, and we found some problem, breathlessness, and in X-ray some fibrotic changes, some abnormality, then gone the CT scan thorax and found defect, abnormality there. And when spirometry is restrictive or mixed, but DLCO is normal. So what could be the treatment modality? Patient should be advised antifibrotic to progress into a disease. We are suspecting that this case may turn into the ILD full blown. So antifibrotic is indicated here or not?
Sir, yes, sir.
Number one, sir.
Sir.
And number two, is there any gene therapy? Because we are changing and thinking of the lung transplant, which is a very difficult, tough, costly, and long queue and huge number of patients. So is there any research or public things? I'm not aware. So is there any gene therapy like things are in the pipeline in upcoming days for this IPF and ILD?
Sir, as far as the first question is concerned, the role of antifibrotics. Now, the antifibrotics are classically indicated in patients with IPF, number one, and in patients with some of the progressive pulmonary fibrosis. The progressive pulmonary fibrosis are those patients which are not IPF and which have shown over a period of last 1 year deterioration in symptoms and deterioration in pulmonary functions over last 1 year. I mean, some people say it's a dog's breakfast definition, but whatever. The recent guidelines say that antifibrotics to be given in IPF, in some of the progressive pulmonary fibrosis, and in patients with some of the connective tissue diseases associated ILDs like definitely like, systemic sclerosis. So apart from this, they say that antifibrotics should not be used, but that's a very bold statement. As you pointed out, the ground level reality is that we get to see a lot of ILAs. So what do? The patient has come to us for some other reason, we find that ILAs are there on a CT. So the best that we can offer is we can have a close follow-up to these patients. So if we find that the ILAs are actually progressing, the ILA, which is they have classified it as fibrotic ILAs and non-fibrotic ILAs. So if they are progressing, we put them on antifibrotics, definitely.
When there is a definite diagnosis,
Sir.
not biopsy, but CT scan wise
Yes.
Diagnosis,
Yes.
that the patient has turned or changed into a IPF, interstitial pulmonary fibrosis, then only antifibrotic is indicated, not before that. Number one point is this.
Sir.
And my one question is also this, that we can take the help of, current times you have told the artificial intelligence.
Sir.
We put all the data on different types of AI.
Yes.
And take the help of even the CT picture is also put on the AI with clinical signs, symptoms, and the short history, and the spirometry and DLCO. If it is not matched, so we can take the help of this chat, any AI. There are a number of AI.
Certainly, a lot of work is being done on those lines, sir. A lot of work is being done on those lines. AI is coming in a very big way, sir. A very big way. Already there are algorithms in the CT which are used for picking up these changes early, much before a manual reader, or to avoid the inter-observer variation between two radiologists or two pulmonologists. So we definitely take it. The caliper is one of these software. There are so many systems which are already in place. Sir.
Thank you, Dr. Sen, for such a lucid interpretation of the things. And AI is also in sort of formative years.
Sir.
AI कहीं और से नहीं आ गया है, जो हमने जो उसको बताया है वो नंबर ऑफ डॉक्टर्स का एक साथ पूल इन करके बताता है, तो इट इज स्टिल वेरी वेरी अर्ली एंड इन लर्निंग फेज. बाकी डायग्नोसिस इज द मेन. एक बार कायदे से डायग्नोसिस हो गई ठीक है, बट अगर आपने बता दिया कि इडियोपैथिक है तो यू आर साइनिंग एट दैट सेंटिमेंट. अ बिग राउंड ऑफ अप्लॉज फॉर डॉक्टर कौतुक सर. थैंक यू.
Wonderful. I would request both our speaker and the chairperson to come down for the felicitation.
L.